Good evening. Thank you all for joining us. If this is your first time joining us, welcome. If this is your second time joining us, thank you for joining us again. This is part of an ongoing series hosted by the International Association of Advanced Medicine and Science. I'm Dr. David Popoli from Wake Forest Baptist Health. I'm the chair of the medical committee for IADAMS. As part of our ongoing series, if you joined us for last time, we had the Boston Ballet and their treatment team. This evening, we're going to move on, taking us around the nation. We'll be talking to the treatment team and dancers from Jacob's Pillow. So I will, at this point, turn it over to the panelists to allow each of them to introduce themselves. And we will start. We're going to go by alphabetical order. So I'll let whomever is first go first.
I'm Stephanie Swensen Buza. I'm an orthopedic surgeon specializing in sports medicine and hip preservation at HSS.
And I'm Kathleen Davenport. I'm a physiatrist at HSS Florida, and I'm on the board of IADAMS.
Hi, I'm Madeline Ho. I'm a dancer with the Paul Taylor Dance Company and also have a medical degree.
Hi, everyone. I'm Jason Mayerhofer. I'm a physical therapist with the Hospital for Special Surgery in Manhattan. I provide the oversight for the Jacob's Pillow volunteer relationship that we have, and I was one of the treating clinicians for Madeline.
Hi everyone, I'm Kristina Quirolgico. I'm a physiatrist also at the Hospital for Special Surgery in Manhattan, and I specialize in sports and performing arts medicine.
Awesome. And we're going to get started with questions. So today we're going to be focusing on a specific case, and Madeline has been so kind as to come in and let us talk about her injury that we had. So we're going to go ahead and jump right in with Madeline to tell us about your injury from the dancer perspective. I know you also have an MD, but as the dancer too, was this a chronic injury that flared up, an acute injury? How did you happen? You know, what were you feeling at the time?
Yeah, so I had never had any hamstring injuries in the past, but around mid-May or so, I started noticing this discomfort in my glutes, like in my butt, and it was sort of hard to pinpoint exactly where it was, but I could tell that there were certain movements that would always irritate it. So I was able to perform and dance and take class and be in rehearsal just fine. It wasn't impairing my dancing and it wasn't inhibiting me from doing day-to-day life activities. But anytime I would go into tendu, so anytime I would go into hip extension with a straight knee, I would just feel this sensation high up in my glutes, and but there was no place that I could really pinpoint it. And it was sort of persistent. I wouldn't feel it while I was dancing, but I would always feel it before warming up and then sort of after rehearsals once I was cooled down again. So, but didn't really notice it initially at first when I was dancing. And then I would say probably around July or so, it became still pretty persistent and it would fluctuate. There were some days that were worse than others, and it was really hard to figure out what specifically was triggering it, and I couldn't figure out if there was any particular rep that we were doing that might have irritated it. And there was no injury, there was no like acute moment where I was like, aha, that's what caused it, right? It sort of just happened, and once it came, it just stuck around and sort of like took up residence there. And so I actually was at Jacob's Pillow at the end of July. And I found out that they had this wonderful service where they had medical providers on staff there. And I was like, well, this has been bothering me still. I feel like I should get someone to take a look at it. Like I had done some acupuncture and we had a PT on our staff that had looked at it a couple times, but it didn't feel like there was any significant improvement. And so it felt, I was just like, I should maybe just get another opinion. This is a great opportunity. We are performing at Jacob's Pillow for 7 shows over like a 3-day period. So I was like, you know, this is a potential for, with that many shows in a row with the same repertoire and potentially making it worse. So that's where I met Jason.
What a great lead in. Jason, can you tell us a little bit about, maybe a little bit about how you first interacted with Madeline and sort of what that how that network occurs between what you guys offer and how you interact with the dance?
Absolutely. So basically, each day that we're up there covering and assisting all students, staff, and performers alike with various injuries, we obviously take precedence to the performing artists simply because of the amount of shows that they have to do in such a short time span. So Madeline came in, and my initial interactions with her were, this was something that was chronic. So to me, it was most likely a soft tissue injury, as it typically is, and something that I really wanted to make sure that was not going on was anything worthy of red flags. So I did my appropriate screening. We're only allocated a short amount of time to be with them, so it really helps you kind of streamline your testing to make sure that there's nothing severe going on. So I had cleared Madeline for all of that. It definitely appeared to be isolated to her glute, proximal hamstring, deep hip rotators, but we weren't exactly sure. But basically, we had to triage getting her back out there for the show. So a lot of the treatment was manual techniques, hands-on, trying to get that tissue to calm down a little bit. And then from there, go through her appropriate warm-ups, make some customization and tweaks, and especially as the nights rolled in, doing some more cool down to make sure that she appropriately calms the tissue down post-performance. So I think we got really on a great page. I did see her basically every day that I was there for the 3 or 4 days, just to continue to provide that triage for her. And I basically established the fact that once she returned back to New York City, where Paul Taylor is based out of, we can definitely do a further deep dive into what things are, that could be causing it, or possible referral out if necessary.
And with that deep dive, so talk to me, and I want to bring Dr. Carlico in here as well. So talk to me, Jason and Dr. Quirolgico, about that transition of having this kind of on-site care to then bringing into clinic care, and what happened then, and kind of how that transition happened.
Absolutely. It allocated me a little bit more time to really dive deeper into what was going on with her leg. Madeline an extraordinary athlete. So my work was cut out for me because it's really pinpointing it. And to me, I'm wanting to get her back to 110%. And if she's stuck and not getting over this hump, I knew I had a great support team behind me. So basically, I was able to initiate treatment with her via direct access, whereby she came to PT prior to physician, picked right up where we left off. We were able to spend a lot more time on facilitating certain muscles to be active. One big thing that we found is that her glutes were a little bit inactive. So going through, and to me, I love to break down the dancer mentality and remind them that you need this foundational strength to perform at this high level. So those are some things that we had focused on. Now, the course of that, with New York State law, we're allowed 10 visits or 30 days, whatever comes first. Unfortunately, with Madeline, the 30 days was rapidly approaching. She was kind of hitting a little bit of a plateau, and in which case I really sat down with her and spoke to her and said, I think we need some physician intervention. I have a great person for you to see. Enter Dr. Q. Was able to really set up a very quick appointment for her, get her seen, and I'll let Dr. Q speak to her piece, but we're able to really effectively and efficiently get her in right away.
So Dr. Q, I think that's a really important, sort of interesting place where you can chime in here, because I think there can be this disconnect, and sometimes there's a lag time between, feeling like an athlete or a performing artist needs to see a physician and then trying to get them to see the right person. One of the things I think all of us struggle with on this panel is we have background training in both sports medicine and performing arts medicine. And those things, although there's some shared, there's some overlap, they're not exactly the same thing. And we can't just send a performing artist to anybody who does sports medicine. That's not always the best fit. So can you walk us through a little bit, how does your clinic sort of make sure people come in a timely fashion, that they're screened, that we can kind of help that navigation process?
Yeah, sure. So at HSS, we have a performing arts program where there's this group of clinicians that it's established, we all know each other, who take care of performing artists, dancers. And so usually if a dancer will see a physical therapist through direct access, but then if they need additional sessions or they need to be further evaluated by a physician like me, then the therapist will usually contact me directly through an email or by calling me, which is what Jason did. So that way we can kind of get the dancer in quickly. Another way that dancers could get in contact with us is to call, we have a performing arts line, and our care coordinator, Brandon Davidson, would then reach out to me or one of the other physicians depending on what the musculoskeletal problem is and help triage them that way, so that way they can get care efficiently, quickly. We do all try to see dancers as soon as possible, especially if they have upcoming performances and it's time sensitive.
And Dr. Buza, from a surgical standpoint, it sounds like, fortunately, this case did not require surgery, which is great. But I know sometimes if there is a serious acute injury, the surgery can be on a clock. There are certain surgeries that we can wait and delay and hopefully never do surgery. And then there are other surgeries that might be on a clock. So can you talk about this whole interaction of care? Because it sounds like, a lot of times dancers might start at any point here, start with the surgeon, start with a physical therapist, start with a non-surgical MD. How do we transition into that surgical realm when it's indicated?
Right, definitely. There are some injuries, like you just said, especially tendinous injuries, which it sounds like this one could be. And if it's a complete injury, then you'd want to involve surgical care earlier. So kind of what everyone was saying, really communication throughout the whole thing with the initial evaluating provider, whether it be, like you said, a physical therapist or a non-operative sports medicine or physiatry physician evaluating the patient, but then also involving a surgeon earlier to see if there is urgent MRIs or other imaging that might be needed. So it's really about the communication from the ground up.
And Madeline, what was your experience with this process in terms of, had you experienced something like this before, of having someone really kind of tee up a path to treatment? And if you did, what was that like? And if you haven't had that before, what was your experience with having your process be navigated that way?
Yeah, absolutely. This was a very seamless process for me. I love that I was able to see Jason at Jacob's Pillow and be able to still continue that care afterwards, because he was someone who really understood, he understood the type of dancing that I was doing. And then to be able to continue that without having to have like a new evaluation by someone else, just to have that continuity of care was really wonderful. And this was something that couldn't be fixed in one session per se. So being able to have that longitudinal care was so important to me. And the whole process was just really seamless. Like when Jason was like, well, the 30 days are up, but I think there's still more work to be done. And, I felt very similarly, because I was like, I feel like we've made progress, right? Like the pain was definitely dialed down. And I could tell that we were making progress, but it was still sort of persistent. And, Jason was like, I have ideas for where else we can go from here. And I was like, that's awesome. Like there's a whole plan in place. And so after seeing Dr. Q, it was really, as someone who is interested in dance medicine, I had seen different, tests for looking at dancers and sort of specific for dancers. So it was really cool to see a new test that I actually hadn't seen before, where she had me do like really successive leg raises or like batmas laying down. And with that, I was like, oh, what was really keeping me from doing more on the right side compared to the left was actually this interior sort of like sort of more popping sensation. And Jason was like, great, we can work on that, right? Like if that's the limiting thing, we can work on that. and Jason was constantly in communication and contact with Dr. Q, so there was this seamless communication. You know, in our healthcare system that sometimes is a little more fragmented, this was something that was really great to see, that seamlessness between providers. Yeah, and for me, having dance medicine specialists is so important to me. So I found out about dance medicine actually when I had an injury back in college where, you know, I went to a sports medicine person and they're like, you have Achilles tendonitis. And I was like, I don't think so. It's definitely lateral and not posterior. You know, and I was told, which I feel like I've heard so many times dancers say, well, then you should, if it's hurting you to dance, you should just stop dancing. And, you know, I think that further alienates the dancer. And that's actually when I learned about dance medicine, when a friend was like, you're not really walking well. You should probably go see somebody. And as soon as they saw me, they're like, this sounds like an osteogonum, even before an x-ray. And so that was definitely my, my first encounter with dance medicine and dance medicine providers. So thank you all for the work that you do. It's so important. For dancers who haven't encountered them yet, this is definitely such a wonderful resource and just so valuable because these are providers who care deeply for dancers and understand not just the injuries that dancers have, but also dancers' needs, right? So like I was able to talk to Jason and say, well, these are the performances I have coming up. What are things that I should look out for? What do I need to modify anything? I don't think, like, there's nothing that I'm doing that is necessarily, like the pain is necessarily preventing me from doing things, but what should I look out for? What are things that might make it worse? You know, and Jason has come to see performances, so he like knows the Taylor style and just has a deep understanding and like thoughtfulness and care for the dancer. And that's just something that really is, yeah, just amazing.
Okay, thank you so much for the love, sending love right back from all of the dance medicine specialists to the dancers. So thank you, and we'll welcome you into the dance medicine fold as well.
We didn't even pay her to say that.
Yeah. So I want to get to a little bit meat of the injury and the diagnosis as well. So Dr. Carlico, can you talk about, you know, some of these tests that Madeline was mentioning? So what are some of the tests that you ran her through or that you typically run through? How did you come to this diagnosis? How did you put together a treatment plan? What was the diagnosis that you arrived to at the end? Kind of where do we go from here?
Sure. So it helped having a good communication from Jason's observations and his input as well. So it kind of already put in my mind of, you know, what could be going on. And then the exam kind of just honed it in and confirmed basically the diagnosis. So on exam specifically, she didn't have any tenderness of the glutes or the hamstring muscles or the origin of the hamstrings at the ischial tuberosity. Her range of motion of the hips was full, it was painless. She had full strength in all directions with all muscles, except when I had her lying on her stomach, prone. And I tested knee flexion at 90 degrees, 45 degrees, and 0 degrees. So at 90 degrees and 45 degrees, she had full strength and it didn't have any pain. But then when I had her with her legs at 0 degrees, and then she tried to bend her knee up against resistance, that actually reproduced the pain that she had at the origin of her hamstrings. The other thing is that, unfortunately, our exam rooms don't have a lot of space. So we can't have her, you know, I couldn't have her do some of the dance moves that could possibly trigger the pain. So you have to get a little bit creative in terms of some of the functional assessments you can do with the limited space. So she mentioned a couple of them where I had her do repetitive releves. I also had to do single leg squat or a ground plie in parallel, and had her do bat mas when she was lying on her back. So for that specific one, doing bat mas when lying on the back, I had her do 5 on the unaffected side rapidly, going all the way up to 90 degrees and all the way down almost to 0 degrees, but not hitting the table, as quickly as she could on the unaffected side. And then I had her do it on the affected side. And I asked her to tell me, well, if this is 100%, you know, on the unaffected side, what percentage would you say you feel on the affected side where she's having the pain? And she told me it was 70%. So just using that all those things put together kind of helped hone in that this does seem that it was coming more from a proximal hamstring strain, possibly including likely the deep hip external rotators and extensors, possibly insertional tendinopathy, but not a rupture. Otherwise, she wouldn't have been able to resist me as much as she did with testing the hamstrings at the different degrees. One other thing that you always have to keep on the differential when it comes to posterior hip and buttock pain is, could it be coming from the lumbar spine, the lower back, especially if there's like a pinched nerve in the back. So I included in the exam provocative maneuvers that would reproduce that if that were the case, such as a slump test. Did I get cut off? Sorry.
No, you're still good.
All right, I got like a flashing thing that said my internet's unstable.
No, you had a moment, but you're back. We're okay.
Okay.
You heard everything. So keep going. Yeah.
Okay, good. Okay. So the provocative maneuvers. So one of them is called a slump test, where you have them sitting at the side of the table, and you basically have them put their chin on their chest and slouch forward, and then you lift one of the legs up and see if it reproduces pain that goes down the back of the leg. Normally that would put a nerve that's irritated coming from the back and innervating the back of the leg that would reproduce pain. It was negative for her. When I did a straight leg raise, a passive straight leg raise where you just keep the leg straight when she's lying down and you lift it up to all the way, basically. And if that reproduces pain that goes down the leg, that would be also a positive provocative maneuver that maybe could be a pinched nerve in the back. But for her, it didn't go all the way down the leg. It only reproduced some pain, a stretching pain right where the origin of the hamstrings were. So basically all those things put together kind of clinched that diagnosis for me that was most likely a chronic strain of the proximal hamstrings.
Can I ask a brief follow-up question, just because I kind of heard you talking about how you would combine history with physical exam maneuvers, and I know that I'm being a little bit coy here because hopefully this is all what we're taught to do as physicians, but I feel like sometimes we get overly reliant on imaging modalities and we want to send everyone for MRI or ultrasound, et cetera. So maybe we can kind of put this out to the whole group here. Can you talk a little bit about how maybe using functional testing for someone who's a performing artist, or even, I guess, the broader athletic population as well, why might that be superior in some cases to just saying like, okay, we'll just wait until we can get imaging?
Well, the whole purpose is you're trying to get the dancer back to dancing, and we're focusing more on function. So a lot of times imaging, it shows everything. And so unless you kind of have an idea of what you're looking for, sometimes you might have what we call incidentalomas, where you'll find things that might just complicate the picture and it might not necessarily explain what's going on. So that's where the exam, especially functional testing, is really superior than an actual image.
Thank you. I guess the next question would be, once we've made that diagnosis and we've maybe transitioned from on-site care, sort of at dance company, what other sort of opportunities are available when you transition that care to in clinic? So I guess I'll tee this one over to Jason to talk about how we might have enhanced care once we switched venues.
Yeah, I think time is a huge factor. Anytime you can spend more time with someone, you get to dig a little bit deeper. You get to know them a little bit more. You get to see certain patterns. With the Jacob's Pillow relationship, it's challenging because of how quick the appointments are set up. We are meant to prioritize and treat as effectively as possible. And when I was able to open up my schedule for Madeline, I was really able to almost double the amount of time. So my treatment phase went from triage, get her back to performing, to long-term let's solve this problem, get you your pain relief, and get you back out performing pain-free and without any substitution or deviation. So that's kind of how it transitioned from on-site at Jacob's Pillow to HSS in the city, to really help structure where we were going to be heading with our treatment program.
And to Madeline, I wanted to also ask, and I think Jason, you might also want to chime in with this question, or anyone else can feel free to chime in, because I know also working with dancers, one of the challenges that we get to, and sometimes with other athletes, many times with other athletes as well, or high level individuals, is that we get to this point with physical therapy where we're there, physical therapy is going great, but we have this moment where we have to go from physical therapy to rehearsal on stage, you know, and sometimes this can be a gap, you know, where we're like, okay, you're done with therapy, but maybe we're not on full performance, and how do we bridge this gap? Can you both talk about, from the therapist perspective and the dancer's perspective, maybe Madeline, if that's happened to you in the past, or what this experience is now, tips, tricks, things that we do to make sure that we're getting our dancers, as Dr. Carlico said, back to dance, not just like back okay. So that's where we're going.
So that's something that, to step even further back, that's something that, you know, as Dr. Popoli had mentioned, this is something that many people face once you hit that transition, that PT's kind of maximized your benefit, and now you need to transition back to your sport or your dance or whatever it may be. And there's this gap and this reserved nature that you just don't want to let them go. The dancers or the athlete has been established with you for so long, and now you have to kind of part ways. What's the best way to release that? And as we mentioned earlier on in this talk, that Madeline had mentioned, was I personally feel if I am not as familiar with the style of dance or the company, I have to see what they do. So I was fortunate enough to see, amongst the many Paul Taylor programs that are out there, I was able to see quite a few up at Jacob's Pillow. And then I was invited to attend a Lincoln Center performance where I saw quite a few more of Madeline performing. So I made a ton of mental notes as to what we needed to focus on. I touched base with her post-show as to where she felt deficiencies were still at. And then come the following week, we go right into it. And something that I pride my treatment technique in is to focus on the things that are challenging on the stage. It's not simply just doing certain motions that are in a controlled environment. I want her to replicate exactly what is going on in stage. And I'm fortunate enough amongst the clinics that we have at HSS to have the space, as Dr. Q was mentioning, sometimes it's hard to find space in Manhattan, but at our PT clinics, we have tons of space to afford us to do these movements and work on these things. I also love videos, and I'm thinking about posting a couple of the videos of Madeline, with her permission, on the Facebook channel, if possible, so you guys can kind of get a glimpse at some of the basic exercises I had done with her that are undance related, but she just had a strikingly hard time with, having her work with those at home, and then building up for that time that she could spend with me in clinic to really focus on the dance maneuvers and perfecting her technique with supervision and customization.
I'm going to jump in here too, because I think I'll tie this into Madeline here. One of the questions we just got on the Facebook page was asking about how do these teams, physician, physical therapist, dancer, surgeon, how do we interface and make best use of certified athletic trainers, and where might that role be, perhaps maybe in this time frame that we're talking about right now? So I don't know, Madeline, if you've had experience with working with a certified athletic trainer, or Jason, you two, kind of where that might fit. What's the role for a certified athletic trainer in this?
I have not worked with that many athletic trainers. So Jason, this question might go to you. But just to add on really quickly, I think one of the things that Jason did really well, which he touched upon, was it's really helpful initially, right? Like to have those controlled environments of doing those exercises, like really isolating the glute muscles to make sure that they're firing and they're working. But to take that and then translate, because I'm like using all my brain power to be like, okay, fire, go, right? And then when you're in the heat of the moment doing the choreography, you aren't thinking about those things. And so how do you bridge that gap between those controlled exercises, from doing those clamshells to doing those like sidewalks, and to bring that to that next level of making sure that when I'm dancing, my muscles just know that that's the firing pattern, right? It's really like retraining, because the other thing about dancers is that we're really good at compensating and cheating. And so I was making things work, right? And so Jason was always watching me. He was like, okay, you made that work, but that is not what we're looking for, right? And so to have someone be able to watch me, not just in the control environments, but doing more functional exercises, that is what then gets you to that place where when you're dancing and doing those big movements or doing all the things that you're trying to focus on in terms of the choreography, to be able to draw on all that training and that repetition of retraining the muscles to do something that, that basically breaking the cycle of what caused the injury in the first place.
To revisit the athletic trainer piece, I haven't personally worked with an ATC in those situations. However, knowing capabilities of certain ATCs, and I know every state has a little bit of a different law stipulating what they can or cannot do. I don't see why they couldn't be involved, especially if they have a background in dance and can understand. I know many ATCs can do some soft tissue triage, taping techniques, things along those lines, which I think would definitely help build and expand on the interdisciplinary approach that we're discussing tonight, where maybe there's an ATC instead of a PT that is overseeing a company and picks up on an issue, refers up to either a PT or a non-operative physician, and then it goes from there. So could the potential be there? Absolutely. We in our team do not have that established as of yet, but that doesn't mean that it cannot be established.
Yeah, I know of some places that have ATCs as as like their primary, like the initial provider. I think SUNY Purchase I think their program with the dance medicine provider is an ATC.
Yeah, there are several professional companies that use ATCs as it would be an ATC instead of a PT who might have evaluated you at Jacob's Pillow. A lot of people do that kind of sideline coverage in the athletic trainer. So that's awesome. So thank you all for that. And I'm so happy that, Madeline, you were able to get back to dance and make it. But I want to throw back to Dr. Carlico and Dr. Buza. Let's say this hadn't gone well. So this was a case that it went well and we were very happy about that. But let's take the flip side of hamstring injuries. All of us in medicine and a lot of us who unfortunately have experienced them know that they can be very, very difficult to get on top of. They do take so much retraining, and Madeline, you're such a great patient to go through all that painful retraining of taking your muscles. So thank you for doing what you need to do with your therapist. So yay. But let's take the flip side of, let's say you're the most invasive patient in the universe, which you are, but maybe your body doesn't cooperate with you anyway. So I want to flip it to Dr. Carlico and then to Dr. Buza to talk about the next steps from the non-surgical standpoint. And then, what does a surgery in that area look like? It's for me as a non-surgical doctor, I get very scared about surgery there. And so I really also want to hear the newest surgical techniques that are out there, how we address that first non-surgically and then surgically.
Sure. So if she wasn't getting any better, then we would move forward to getting further imaging, like an MRI of the hamstrings or an ultrasound. And then depending on what it shows, if there's a partial tear, then we would move forward with some more interventional type of things like PRP injections, or I also do extracorporeal shockwave therapy. And the key thing here was having frequent communication with Jason to kind of see how her progress was, knowing that if she wasn't getting any better, then we would proceed down that branch point.
And then we usually try to exhaust all non-operative measures, as you were saying, including injections, PRP. If it was considered to be a high-grade partial or a complete tear, then there are surgical options at that point if nothing non-operative has worked. And that would be in the form of debriding the area and then repairing the tissue with suture anchors, where we really just clean off the bone, the sit bone and the ischium, and bring the tendon right back into the bone to allow it to stimulate it to heal.
I guess I'll pick up the sort of next question here, which would be, you know, I can see how this whole experience could certainly be frustrating in the idea of, you know, you have this initial injury, you might get sort of bogged down and feel like you're sort of overwhelmed. And I guess I'll kind of leave this with Madeline, which is, you know, kind of if you could give us an idea of the sort of summative experience you had. Yes, this could have been, you know, on one hand, this could have been something truly horrible. And of course, nobody, especially any performing artist, does not like to discontinue his or her activities. So maybe how would you, if you could give us sort of an idea of how this may have been a reframing experience for you, that, you know, it could have been something potentially very upsetting, but maybe, I don't want to put words in your mouth, but might have actually ended up being something that was positive.
Absolutely. I mean, it was one of those things with any dancer, any sort of injury or anything that prevents you or hinders you from dancing is not just a physical hindrance or a physical barrier, but it's also emotional as well, right? Because dance is such an integral part of my identity. Anything that threatens that is not just like an identity threat, but also like a career threat, right? So there are all these different factors at play. So one of the things for me, when, you know, I've been very lucky and I haven't had major injuries, but, you know, it's one of those things where when there is something going on, as dancers, we're very aware of our body and know when things are not right. And oftentimes our tendency is to try and push through it. And there's always that balance of knowing, and, you know, this is one of the things that Jason talked about, of like making sure there's no red flags, right? And so the question is always, is there something that could be worsened by continuing to dance? Or is this something that you can continue doing? What are the modifications, thinking about those things? And so being able to know that was something that was very reassuring, to know that this was something that was there and persistent, but it wasn't something that would necessarily cause further damage or worsening per se. And it was something that was frustrating and was constantly there, but it was also a wonderful opportunity for me to be able to do the retraining. And I have to say, because of the retraining, I'm actually stronger because of it. You know, I knew that my glutes were weak. I know that I'm very quad dominant, as a lot of Paul Taylor dancers are. And it's actually kind of a pattern, right? Like, and this is something that you see among companies, whether it's repertory related or something that causes it, but it was, people sort of manifest lack of glute strength in different ways in our company. But learning about this, I knew it was something I needed to work on, and had sort of done some sporadic strengthening, but not in such a rigorous, thought out longitudinal way. And so having that program and working with Jason, knowing when I was cheating and compensating and recruiting other things to help me, that was so helpful because it made me more aware of my other side as well. And because of that, I feel like my confidence in my body, because like balance was never something that I considered my own strength, but because of all this retraining, I feel much more confident in balancing. And it was pretty cool to be able to show Jason sort of further along in our working together that at Lincoln Center there was this one dance that required a lot of balancing, and it was something that for me caused a lot of anxiety. And because of all the things we had been doing, I was able to show Jason, I was like, this is the progress. Like, you're literally seeing on stage the progress that has been made by your work, right? Like, that's a pretty amazing thing to see, where I started. If Jason has the videos to see, you'll see like just the amount of like lack of coordinated firing compared to the things that I could do at that time. And so to me, injuries are never fun. Injuries are never something that you want and hope for. But with this, I feel like I was able to actually become stronger because of it.
Well, thank you very much. I mean, I think we're probably over by just a couple of minutes here, but I really want to take time to thank the whole panel. This has really been an excellent experience, and you know, your expertise and your insight, these are all really valuable. And you know, that's the whole point of these seminars, is to share with the broader dance community, you know, what they should be looking for, not to fear seeing the medical community. We're not all monsters. I mean, I have horns, you know, but so your experiences are really valuable, and I really appreciate y'all being here tonight. I will stop the recording and take us off Facebook Live, if you don't mind hanging on for just a second.